Hi class. I figured I would start to record some of our lectures. Since we can't be in class together, I figured you might want to listen to a few of them, help you through some of the readings. So this is chapter 8. This is schizophrenia spectrum and the other psychotic disorders. So here's some things we're going to touch upon: some symptoms, diagnoses, the course of the disease, biological theories, and psychosocial perspectives. So psychosis is defined as the inability to differentiate between what is real and what is unreal. In all of the psychotic disorders, we have two sets of symptoms. Psychotic symptoms are grouped into two groups, positive and negative. Positive, I think of them as the excess of things. Often these are sensory experiences that we're having that are in excess of reality. Negative symptoms I think of as lack of or loss of certain symptoms or abilities, like affect, expression, motivation. So one thing about positive symptoms is they could wax and wane. That means sometimes during a particular disorder, positive symptoms can be really expressed and individuals can really have a problem with them, and then they might disappear for several months and then reemerge. Negative symptoms are often more chronically expressed. They stay more solid and stable in terms of their expression for an individual person. Schizophrenia, so one of the more severe forms of psychosis that we're going to be talking about. Really, it's where an individual alternates between clear thinking and communication with an accurate view of reality and proper functioning. But then during their acute phase of their illness, where they're having most of their symptoms, there is a psychosis in which they lose touch with reality. They often experience some of those positive symptoms. They often have trouble with disorganized thinking and speech, odd behavior. They are unable to perform daily activities, which often include self-care. Actually, more than 90% of individuals that seek treatment in a mental health facility annually are those that have schizophrenia. So you'll hear a little bit about how severe the disorder is and how often it requires hospitalization. And most who develop psychotic disorders do so in their late teen years or their early adult years. So this schizophrenia spectrum, we have a variety of disorders that are present on this spectrum, which goes from mild to more severe conditions. And obviously the most severest condition on the continuum is schizophrenia, as being the most severe manifestation of psychosis. And the least severe is like a brief psychotic disorder that we're going to talk a little bit about later. What determines where the disorder lies on the spectrum or on the continuum is really in terms of how many symptoms people are experiencing, what their severity is, and the duration or how long those symptoms last. So let's talk about some of the positive symptoms specifically. So positive symptoms, again, are overt expressions. They're unusual perceptions, thoughts, or behaviors. Delusions, right? Ideas that an individual believes to be true, but that they are highly unlikely or impossible. We will talk on the next slide about some different delusions that are quite common in psychotic conditions. How about hallucinations, right? Perceptual experiences that occur without an actual stimuli. Those perceptual experiences can affect any of the five senses. And actually the most common hallucinations are auditory hallucinations. This might be where a person hears another voice speaking to them, or a person issuing commands or instructions to them. The second most common hallucinations are visual hallucinations. This might be where a person sees something, but the actual stimuli is not present in reality. Some of the other positive symptoms are formal thought disorder, disorganized behavior, which can include catatonia. So formal thought disorder, schizophrenia, involves a significant problem with thinking. It's a state of highly disorganized thinking. There are several examples of this type of thought disorder in the book. Often it involves loose association or total derailment of thought process. It could be a tendency to slip from one topic to the next. They change quite frequently from one topic to the next. Often it could change within the same sentence from multiple topics, all within the same sentence. There's very little coherency often to people's thought processes and their speech patterns when they have a formal thought disorder as part of their positive symptoms. Behavior can be quite disorganized. It could be purposeless. It could be highly unpredictable. Usually behavior that has a lot of motor agitation can be unpredictable. The flip side of highly agitated behavior would be catatonia, where you have disorganized behavior that reflects more of an unresponsiveness to the environment, where the person can become mute, or they posture, where their body movement becomes very rigid, very still, and they hold certain postures for hours. It could be a good example of that, or sometimes the people that are doing mime on the streets, right? So it's where they're holding positions. I often think New York City is one of my favorite spots to be. And in Times Square, you often have people dressed in costumes that are holding positions for a long time. Now, I'm not suggesting that those people are schizophrenic. I'm just offering you that that's a really good example for someone who's holding a very catatonic position. Here are some of the examples of delusions. Some of the most frequent ones to occur in schizophrenia are the persecutory delusions, thought broadcasting, and thought insertion. So persecutory delusions, right? False belief that one or one's loved ones are being persecuted, watched, or conspired against. Most commonly for individuals with schizophrenia are persecutory delusions that involve the police or CIA or FBI. Often thought broadcasting, or belief where one's thoughts are being broadcast from one's mind out into the environment for other people to read and hear. Thought insertion, belief that another person or an object is inserting thoughts into one's mind. If you all have ever seen the movie A Beautiful Mind with Russell Crowe, there's a lot of examples on there about different delusionary thoughts and behaviors that he engaged in throughout the movie. Let's move on to some of the negative symptoms. So negative symptoms are certain behaviors or emotions and motivations that one would expect to see in a normal person that are absent in a person affected by schizophrenia. So I think of negative symptoms as being a deficit in functioning, an absence in someone's capacity. Restricted affect, right? An absence of emotional expression. We often refer in the field how the person has very flat or restricted affect, which means they don't really have much range of an affect. It's pretty much solid and plain. Avolition, the inability to initiate or persist at common goal-directed activities. And then, of course, there's a bunch of cognitive deficits that occur as part of negative symptoms. Basic deficits in one's ability to hold attention, their memory, or the speed in which they process new information. So schizophrenia, like all the other mental health disorders that we're talking about, are outlined in the DSM-5. That's a Diagnostic Statistical Manual. And actually, schizophrenia was first recognized as a disorder in the early 1800s, and it was first characterized by Emil Kraepelin. So in the DSM, part of the diagnostic criteria is making sure that criteria for both positive symptoms and negative symptoms are met. The positive symptoms, again, will really only generally last during the active phase of the disorder, and so they might last for a month and then disappear quite often for a couple of months and then resurface. So just something to really think about. The negative symptoms are really more chronic. They're often expressed more frequently for individuals throughout their entire disorder, but the positive symptoms are more active during the active phase. Now, prognosis is something that is overall, unfortunately, very poor for individuals that experience schizophrenia. Even sometimes with treatment, many of the medications that we're going to talk about that are reserved for treating individuals with schizophrenia have a great deal of side effects, and often individuals stop their medication, which leads to a very chronic and debilitating illness. It's one of the most severe illnesses that we're actually going to talk about in terms of this course and the set of disorders that we review in this course. Rehospitalization is often very common for individuals with schizophrenia. That's being in and out of the hospital, admitted in and out of the hospital quite frequently over their lifetime. Sometimes individuals that are discharged, they're rehospitalized between 50 and 80% of the individuals with schizophrenia. 10 to 15% commit suicide. And some may reach some stabilization point, but it's usually not until like 5 or 10 years after their first psychotic episode. So individuals can suffer with the disease for quite some time. Some of these other psychotic disorders are actually not showing up in the slide. Some of the titles here are very light. Apologize about that. But one of the other psychotic disorders on the schizophrenia spectrum is schizoaffective disorder. That's a mix of actually symptoms of schizophrenia and a mood disorder like depression or mania. Another one that we're going to talk about here is schizophreniform disorder. Sorry, can't see that again. That's symptoms of schizophrenia present for less than 6 months. So again, that usually involves the positive and negative symptoms of schizophrenia. But unlike schizophrenia, schizophreniform disorder is present for less than 6 months. Also, this last one here is brief psychotic disorder. This is on probably the lowest end of the continuum, and it involves sudden onset of delusions, hallucinations, disorganized speech, or disorganized behavior, but again, lasting for up to only 1 month. Lastly, some of the other psychotic disorders, we're going to reserve speaking about schizotypal personality disorder. We'll talk about that when we hit the personality section. Let's continue with just then delusional disorder. This is when an individual really, their only symptom is generally delusions. It's lasting at least 1 month. And it's regarding situations that occur in real life. So again, at the lower end, the less severe end of the spectrum in terms of psychotic disorders. So a number of theories that propose cause for schizophrenia. Obviously, most of the research shows a very strong genetic transmission of schizophrenia from one generation to the next. Knowing that schizophrenia has very similar symptoms across different cultures, across time and generations, we realize that the biological factors are key in terms of the transmission of schizophrenia. We can also look at some of the family studies, adoption studies, and twin studies to give us a good idea about generally what we see is that individuals are born with a genetic predisposition in their biological makeup, and then it's usually some type of environmental factor that influences the manifestation of the disorder. But we definitely see proof of inheritance, both in family, adoption, and twin studies. Another set of biological theories really focuses around the structure or the function of the abnormalities in specific brain areas. So what is that? What do we mean by that? Schizophrenics have different brains than normals do. And you can see that there's differences in the structure and the functionality of some areas of the brain. Some of the structures in the brain are much larger. So the ventricles are enlarged, leading to some of the gray matter around that area to be smaller. Or decreased in volume. And so we sort of see some other larger ventricles back here as well too. too. Even some abnormalities, right? You see the little hot spot here. Different areas are light up in the brain with more difficulty. With the normal brain, where you see a good distribution of some lighting up areas in terms of cognitive processing. Here you see a real abnormal pattern in terms of how that brain is responding to some stimuli in the environment. We also have seen some proposition of biological theories in terms of schizophrenia being caused by different birth complications or prenatal exposure to different viruses that affect brain development. And then lastly, under our biological theories is all the neurotransmitter theories, and believing that there's an excess of dopamine that contributes to the development of schizophrenia. Let's skip a little bit over to some of the psychosocial perspectives. Early on in time, there was a strong belief that families, particularly mothers, developed schizophrenia in their children by certain interactional patterns that they had with their children, by being overprotective or highly rejecting. We now know that although stress sometimes can contribute to relapse in schizophrenia, stress alone or environmental triggers alone without genetic contribution do not cause the development of schizophrenia. We have seen some interesting social determinants in terms of schizophrenia. So there's a social drift theory that talks a little bit about that. It tries to explain the significant association between individuals that have been diagnosed with schizophrenia and low social status. So it explains that there's a tendency to drift downward in social class compared to the class of one's family of origin. And one's believe that that downward drift might be caused, obviously, by the schizophrenic symptoms that interfere with one's ability to complete education or hold a job. We also see that there's an increased rate of individuals with schizophrenia that are born in large city areas, and that can be related to a higher risk of prenatal exposure to infections or other carcinogens. We also see that stress increases the risk to develop schizophrenia and is most certainly linked to more frequent relapses of the disease. Families stunt the growth of the autonomous sense of self. That's sort of our schizophrenogenic mother theory that is believed that families can really unfortunately contribute to one's lack of growth or proficiency with someone that's been diagnosed with schizophrenia. We particularly know that families that have a high degree of expressed emotion, their family members are high degree of expressed emotion amongst family members is associated with a poor recovery pattern for individuals with schizophrenia, as well as more relapse. And expressed emotion can be described as families that are highly intrusive with one another, critical, or overly involved. I'm going to skip the cognitive perspectives. They're not really too popular in our field. There's been some theorizing in terms of how schizophrenia might be a natural reaction of the individual. So some of the positive symptoms or negative symptoms are a natural reaction to the person's own awareness of their fundamental difficulties in attention, inhibition, or adherence to the rules of communication. So they actually conserve and limit their cognitive resources. It's not a very popular theory, but wanted to give you an idea about what cognitive psychologists often feel about the development and the maintenance of schizophrenia. There's two categories of biological treatments that we're going to talk about. One is the typical antipsychotic drugs, and then the second is the atypical antipsychotic drugs. So the typical antipsychotic drugs are those older antipsychotic medications that reduce positive symptoms. They reduce the delusions and the hallucinations. They often, unfortunately, cause significant side effects. So they work by blocking the receptors for dopamine, and therefore they reduce its action on the brain. They cause usually significant side effects that can affect one's movement. One's tardive dyskinesia is actually a neurological disorder involving involuntary movements, specifically of the tongue, face, mouth, or jaw. The atypical antipsychotics are they're newer medications. They bind to the D4 dopamine receptors and they influence several other neurotransmitters. So from a biochemical standpoint, they work a little bit differently than the typical antipsychotics. They target both positive and negative symptoms, whereas the typical antipsychotics really targeted more of the positive symptoms. And you can see some of the side effects, although they're serious, they're a little less disruptive to one's life and functioning and movement than the typical psychotics are. There's also a great deal of psychological and social treatments that can be very effective for individuals with schizophrenia. Because there's a high rate of discontinuing of medication because of the difficult side effects that people experience with the antipsychotics, it's often helpful to have some of the psychological or social treatments available that can help with this med compliance and can often offer some education about the disorder to both the client themselves or the patient themselves as well as their family. So these are comprehensive approaches that are used to supplement medication treatment, and they can address different behaviors, cognitions, and social deficits that we see with individuals that have psychotic disorders. We can teach certain behaviors. Often individuals with psychotic disorders really struggle with self-care, with hygiene, and so being able to teach some of those more appropriate and socially adaptive behaviors through operant reinforcement can be really helpful. Often talking and dealing with some of the cognitions. Often individuals that have schizophrenia recognize and have really demoralizing attitudes towards themselves and others. They can get often overwhelmed. They can become profoundly depressed. And so helping change some of their cognitions can be really helpful. There's also some belief out there that doing some cognitive work with some delusions can be really helpful, and doing some reality testing and helping patients to understand what might be a result of their delusional thinking versus real and in reality can help navigate some of those symptoms as well too. Social deficits can teach problem-solving skills, which are needed obviously for everyday interactions, social interactions. Some of the other more as important, psychological and social treatments can include the family treatments. Oh, sorry, I've hit the button one too many times. Families, it's really important to support families. Basic education of the illness can be very helpful for families. Families struggle often in understanding their loved ones' behaviors that suffer from schizophrenia. Family therapy can also help families to understand which negative behaviors to avoid or ignore and which ones they want to reinforce to create more positive behaviors. And family therapy can also help with the impact of stress on the caregivers, provide some support, and help decrease those overall stress levels. Because schizophrenia is such a chronic disease, it can really take tremendous tolls on families, and so family therapy can be quite helpful. Also, one of the effective social treatments for individuals with psychotic disorders are called assertive community treatment programs. These are often comprehensive services that really are designed to meet the patient's needs, and most importantly, they have 24-hour contact from experts that involve medical professionals, social workers, psychologists. They often as well offer self-help groups, social groups, really provides a comprehensive team that can help the patient not only with their medication and the management of their side effects, but also help provide some of the social treatments in the community. So it's really important in thinking about the the psychotic disorders is really focusing on the consensus of where our beliefs are about the development of schizophrenia. The beliefs in the field, the consensus is really around individuals having some type of biological contribution. You can actually start the chart here where an individual has some type of genetic or neurological vulnerability to schizophrenia, usually present at birth. And then depending on the level of stress and their supportiveness of their family, this disease can express in a more severe way or can express itself in a less severe way. So obviously, if you have this genetic vulnerability and you have a family environmental stress that triggers that vulnerability more significantly, you're going to have significant symptoms of schizophrenia. And you can see this interactional pattern go again, in which even when you have developed the disorder, the more stress you have, most often because of some of your symptoms and environmental response to those symptoms, that can trigger new episodes. And then obviously, depending upon what kind of comprehensive biological and psychosocial treatment, you'll see some of the reduction in the symptoms and more positive prognosis. The disease is better managed if you're able to interact with some of those biological treatments, interface with those psychological treatments, get some family, some support here. With inadequate treatment, you're really going to see a more chronic and continuous disease pattern. So some things just to remember in the book, it probably is really important to look to page 224, I believe it is. That provides a chart, table 2, will give you some good ideas about some of the symptoms that can be present. In schizophrenia, it actually gives you the exact DSM-5 criteria for schizophrenia. So you guys can take a look at that. And then I also showed you the table 1 that has the different types of delusions. That is in your book as well. So I hope you enjoyed this overview of Chapter 8, Schizophrenia Spectrums and the Other Psychotic Disorders.